My name is Dr. Kevin Fillmore, and I'm a diagnostic radiologist at Doylestown Health. My area of expertise is in musculoskeletal radiology. I trained at NYU Medical Center in New York City and completed my training in 2008 with a fellowship in musculoskeletal radiology at the NYU Hospital for Joint Diseases. I was lucky enough at the end of my training to find a job here at Doylestown in 2008, so I've been here for the past 13 years, and it's been a wonderful experience working at Doylestown Health. So musculoskeletal radiology can be divided both into the diagnosis of musculoskeletal disease and imaging-guided treatment. We use advanced MRI, ultrasound, CT, nuclear medicine, X-ray technology to diagnose a full range of musculoskeletal disorders in the body. Recent advancements in MRI allow us to make diagnoses of cartilage injuries and detect early arthritis much earlier than we could before. With musculoskeletal ultrasound, we can make diagnoses of tendon and ligament tears while examining the patient real time, so we can see if these ligaments and tendons are actually functional. It's very helpful to have the patient there and speak with them and have them move in different positions while we're doing the examination. That adds a lot as opposed to an exam that's performed with the patient static and not moving. The other arm of musculoskeletal radiology is the treatment portion. There we use imaging guidance with either ultrasound, CT, or fluoroscopy to put a thin needle through the skin surface and target a joint either in the extremities or in the spine that might be painful. Through this needle, we can inject anesthetic and steroids to treat pain. These minimally invasive procedures have a very short recovery time, and the patient can often avoid a more open and invasive procedure, which would have a longer recovery time. So a diagnostic imaging physician is different than an oncologist or other medical specialists in that patients usually don't get to see us. We're usually working behind closed doors and have much fewer patient interactions than other physicians. But patients should know that we're seeing them just as much as their doctors are. It's just we're seeing the inside of them as opposed to them face to face. So we use the information that we find inside of them to communicate our findings to the referring providers. And this diagnosis then goes on and gets communicated to the patient through their doctor. That starts them on the correct treatment path. Before medical or surgical therapy can begin, it's very important to have an accurate diagnosis of the disease. In conjunction with physical examination, the patient's history, and some laboratory studies, often imaging is incorporated in to make these diagnoses. These days, imaging is involved in the diagnosis of most diseases from the head to toe, to either confirm or exclude diagnoses based upon clinical grounds. Once we have the correct diagnosis, then we can recommend the appropriate treatment. Getting on the appropriate treatment path from the beginning results in improved patient outcomes, and here at Doylestown Health, we're able to do that. There have been many advancements in radiology over the past decade since I started here at Doylestown Health. Most of the advancements in imaging involve increased spatial resolution to the images, meaning the images are acquired with a greater level of detail. This increased level of detail allows us to make a more accurate diagnosis. Other advances in imaging that are common across modalities are the speed of image acquisition has been increased. That means patients spend less time in CT and MRI scanners, since the scans can be performed faster. In the area of MRI, there's been many advancements since I first started. We perform very high-level MRI here now at Doylestown, which includes prostate MRI, rectal cancer staging, and advanced neuro and cardiac imaging. There's been advancements in the field strength of the magnets. We now have 3.0 and 1.5 Tesla magnets with advanced coil technology and software upgrades that allow us to do this advanced imaging. None of this was available 10 years ago. The scanners have changed and the design has changed, allowing a more open feel. Patients can now go into the MRI and feel like they're almost in an open system as opposed to a closed system, which was the case many years ago. We also have an ambient experience where patients can look at movies and pictures and listen to music during their exams, and this makes it much more comfortable for them. Patients shouldn't be worried about having an MRI exam, even if they have claustrophobia. The setting is very comfortable, and we get great feedback from our patients. So once the patient's journey ends and they've had their images acquired, be it ultrasound, MRI, CT, or X-ray, they leave the hospital and their images are sent electronically to a computer. There's different reading rooms stationed throughout the hospital where radiologists are viewing images in a dark room, which allows you to have better visual acuity to make diagnoses. When viewing an MRI of a patient's brain, we look at several different structures. We look at the ventricles in the midline to make sure that they aren't abnormally distended or collapsed. We look at the gray matter around the periphery of the brain and the white matter. We look at different imaging sequences to determine if the patient has had a stroke. And we can look to see if there's any masses in the brain or any areas of abnormal enhancement that could be signs of cancer or infectious or inflammatory encephalitis. These are all things we go through in the checklist when evaluating brain MRI examinations to determine if there's any pathological disease. I can remember many instances where we're performing a scan for one reason and found on the images is a cancer in a different area of the patient's body, which currently was asymptomatic to the patient. We're able to detect this cancer and then allow the patient to be treated before they even develop any symptoms. Here, lives have been saved before the patient even had any pain or any symptoms of the cancer at all. So there, we know we've really made a difference in the patient's life. I'm motivated to advance diagnostic imaging at Doylestown Health because I feel that as physicians in the community, we owe it to our patients to provide the very best medical imaging available. That includes investment in new imaging technology, which at Doylestown Health, we've had many new radiology machines purchased over the past several years, putting us in a state-of-the-art position. It also involves training and time commitment on the part of both radiologists and radiation technologists. We've spent a lot of time training to learn the new equipment and how to interpret these advanced imagings. And as a result, it's paid off. We can make diagnoses now that we couldn't before, and both patients and referring providers are very pleased with the work we've done.
Hi, I'm Michelle Kopak. I'm a radiologist here at Doylestown Health. I specialize in breast imaging, and I'm the director of the Women's Diagnostic Center. I've been here for 22 years, and I have seen amazing changes in breast imaging over that time. At the Women's Diagnostic Center, we do breast imaging. What we do at our space is mammography and breast ultrasound. There are two different types of patients, though: screening patients and diagnostic patients. Screening patients are those that are asymptomatic. They have no problems. They want to get in and get out quickly and get their study done. Diagnostic patients are those that have a problem. Sometimes, though, a screening patient might have a problem that is found on a mammogram. They then turn into a diagnostic patient. Screening mammograms are something that's become a bit controversial over the past few years. I'm a radiologist, so I subscribe to the American College of Radiology and the Society of Breast Imaging. In my societies, they suggest that we start screening mammography at age 40 and continue annually. Screening patients are patients with no symptoms. However, of the breast cancers we find, 66% are found on screening mammograms. So they are essential for finding early breast cancer when you can't feel it and it isn't causing a problem, and it can be treated easily and cured. Our goal in the Women's Diagnostic Center is to find breast cancer at its earliest phase. We want it to still be contained within the breast. We don't want it to have spread to the lymph nodes or to the rest of the body, which makes it much harder to treat. When we find it in its earliest stage, stage 1, then it's usually curable. That's the goal, is for us to find it and diagnose it at that point. When I started in the Women's Diagnostic Center, we were doing film screen mammography, which is ordinary type X-ray imaging. In 2001, we moved to digital mammography, which was a major change in the way mammography was performed and really allowed us to improve the details that we could see in mammograms. In 2015, we moved to 3D imaging, which is tomosynthesis. That again increased the amount of detail you could get and the things that you could find. A typical patient with a diagnostic problem, for instance, a mass that they feel, would come in, they'd have a mammogram that would be tailored specifically to that focused problem. Oftentimes, after the mammogram, they would need an ultrasound. That would follow immediately after that. After the two studies are performed, a radiologist, often myself, will come in and give you the diagnostic evaluation. Sometimes that means you need to progress to a biopsy. Sometimes after a biopsy, a cancer is actually found. In those instances, we are very lucky here at Doylestown Health to have a fabulous team who can deal with breast cancer. We've been in the same spot for about 23 or 24 years, and we've more than outgrown it. The new space is double the size, so we are thrilled to be able to have more space. Currently, the technologists actually work in the hallway, and now they'll have their own dedicated space. We are trying to make this a very warm, very cozy space for patients to feel really comfortable in. We will be increasing from 2 mammogram units to 3, and from 2 ultrasound units to 3. So we should be able to significantly decrease the backlog, decrease the wait time, increase accessibility, all of which should make the patient's experience there much more comfortable. We're hoping that our current wait time, which is about 3 weeks for a screening mammogram, will be able to be significantly decreased. We want patients to be able to call and get an appointment within a week. The diagnostic patients, they want to be seen the next day. We want to be able to accommodate them to within 2 to 3 days. It's very anxiety producing to have a problem with your breast. So to be able to get quick discussion of what the problem is and what to do next, that's our goal. I think the main thing that differentiates Doylestown Health from every other place that surrounds us is the staff. The people that I get the pleasure to work with are some of the most caring, kind-hearted women that you can imagine. The empathy that you feel in the department, it is felt by the patients. They appreciate it. I cannot tell you the number of people that I have had say to me, "Thank you so much for helping me through this process. Having a biopsy was not nearly as bad as I thought because you were able to help me to distract me, to help me to laugh over a joke." And that kind of caring that you get from the staff, it cannot be duplicated, and it's what makes Doylestown Health the special place that it is to work.